So I am going to start out with more of a framing kind of presentation and give some examples. Most of this is in the context of kind of clinically relevant, hopefully, aspects. Maureen is then going to talk or focus more on the cognitive sphere and function as well. And then Dan is going to talk more about the later side of the trajectory, those with needs of chronic disease and physical problems. So I just call this frameworks for building evidence for technologies that facilitate independence. So the framework, the first framework actually that we've talked a lot about how things may unfold, this issue of are we talking about health or chronic disease, and it's clearly a spectrum, and one way to, I think, frame this is in terms of prevention, and there's different levels of prevention: primary prevention, secondary prevention, tertiary prevention. Those that are well or worried well have a different set of needs from those who are at risk or who may have subsyndromal or risk factors as compared to those who have manifest disease or chronic conditions. And the opportunities for interventions have to track across those different phases. Another trajectory, which I think we've touched on a lot of this, and actually one of the nice things about being later in the day is I'm reiterating things, so that's sometimes that's a good thing, I hope. It's good for learning. So I think that there's been a focus here on understanding the stakeholders, and that's really got to be the first phase of any kind of research, and framing the question relative to the stakeholders, and who they are is a very important area. It's not just the senior, it's their family, care providers, the public, and understanding how that works, and using different methodologies, whether it's focus groups or surveys, and other methodologies. After one understands that, there's this area of the technology itself. I think the last panel really honed in on those challenges. A lot of this work gets done in smart apartments or places that simulate the real world but aren't quite there, but are needed to develop technologies before they're ready to be scaled out into any kind of community setting. In the community setting, in our own work, we have we call it a Life Lab. It's a bunch of older folks who agree to have the technologies that are in the smart apartment, if you will, in their own homes, and that provides a place to further understand how the technology works in the real world. And the last part, which we've had a lot of talk about, but I think is its own thing, is the data itself. And it's not just the analysis, but the capturing, the storage, developing the analytics, and the outcomes as well. So there's this kind of trajectory that I think generally travels across most research. The other trajectory that we've talked about is this problem of the change in technology over time itself. So on the upper left is the tram up to Timberline Lodge in 1956, which took 20 minutes, and I understand was half the time didn't work. And then on the right, just 50 years later, is a tram from the bottom of the Willamette River up to the top of our campus, which takes 3 minutes, and fortunately still seems to always work. And how you deal with that change. The graph on the bottom is the famous Gartner hype cycle, and I like this just because it brings into focus the consideration of where you are on the development of technology. So going across time, there's something is introduced, like the Apple Watch, for example, and that's an innovation trigger. Then there's this peak of inflated expectations, the trough of disillusionment, the slope of enlightenment, and then ultimately, if lucky, the plateau of productivity. And each of the technologies have their own timeline to pass through to hopefully get to that plateau. But I think it's an interesting way to think about things in terms of timing. And then the last trajectory that I want to talk about a little bit is the evidence trajectory. That is, we talk a lot about what's the minimum standard, what's the minimum amount of information to establish that something works or not, or is effective. And there's this well-worn evidence-based medicine pyramid that I think is useful to frame this idea, starting at the bottom, which is where we are today. That is background information, expert opinion. But moving up through case controls and series to cohort studies to randomized controlled trials, and then moving all the way to the top to systematic reviews. Actually, in this field, we don't have enough studies in most areas to do any kind of systematic reviews yet. So I would say, just as the panel before us said, we're really not ready in some ways, or it's very early. I think the clinical studies in this area are also very early, and hopefully, though, moving forward rapidly. So a couple of examples and how this might, these kinds of considerations might frame questions. So first, an example of primary prevention. So this comes from our own work. This is a randomized controlled trial of using remote sensing kinds of technologies placed in the home compared to usual care assessments to see if the use of the remotely sensed data would help the care providers decrease the need for higher levels of care. And this has not been completed, it's actually in process. But I bring this up because of the considerations, and this just shows just some of the technologies, but this is, I think for most people here, a common suite of motion sensors and physiologic sensors and a med tracker monitoring computer activity that provides that input. But what I really wanted to point out was the real world questions that this kind of research brings to bear. So first of all, the population, particularly in primary prevention, people are healthy, and you often end up with, we've talked about this a lot, early adopters. If you want to understand how things work, sometimes you focus, or often we focus on people who already use computers. So it's just a part of making those kinds of decisions that one has to make. Or you then may decide that you need to design a system where computer input or internet access is not needed. We need to talk more about diversity, and this bears on technology use. In this particular study, one of the communities is in Section 8 housing, and so we want to monitor phone use in the upper socioeconomic levels. Landlines are still very commonly used. Almost all folks in that group who are over 75 have landlines. Actually, in the lower socioeconomic groups, cell phones are much more common. So you have to deal with those differences. And then in people who are healthy, who is the caregiving community? If you, do you really have a caregiver? Is it are your children your caregiver? Well, many independent older people don't feel that way. Another question that comes up is, what's the right comparator condition or control? It's very hard to blind technologies. So if you're putting devices into a home, how do you say that the person isn't aware? Is there a Hawthorne effect, if you will, to having some kind of technology in the home? And then the issue of refusers, we only study people who agree to do what we ask them to do, but we need to also capture those who don't to make things relevant and generalizable. And then lastly, I won't dwell on this, but picking the technologies and tuning them to some of these considerations is important. And in this particular trial, we used only off-the-shelf available technologies, which have their pros and cons, and we focused on these functional measures at a high level. So not, I guess use the example, making linguini, but more major life activities that are mostly time-based. Another example is for secondary prevention. I didn't I was so glad you did the robots, because this is another robot idea. This is not our idea. This is the Vigo company. So here, actually, the person on the video screen, so this is a Telepresence robot, may give the robot a personality. And this company just wanted to test whether the usability of this in a senior's home and have their older children drive the robot around. And we performed this study for them. And it was a very small study, and these were some of the characteristics that were assessed as the person had the robot in their home, as well as the adult child drove it around. And it was, and these are just in the right corner are some results or comments that were made. And it was, I have to say, you know, we all have our biases. It was surprisingly well liked, although not universally. The point of this particular example also, though, is the company, despite, you know, they've done a lot of things, but it wasn't all based on this study, I hope. But they've gone on to actually introduce this as a product that you can buy. It's, I think it's $6,000, and there's a $100 a month service fee. But I don't have any say in the company or one way or the other. But I just, as an example, it brings up a couple of issues. The importance of collaborating with industry. I think we need to be aware that many of the technologies are really developed into products and services, not by academics, but by companies. And so we have to have ways of engaging with these companies and I think there are already best practices and approaches for these kinds of collaborations. Another example of secondary prevention is people at risk for isolation, particularly with mild cognitive impairment. So again, this is a randomized controlled trial that was just completed. The PI, and this is Hiroko Dodge. And this was an interesting study where individuals were given a computer, but they didn't have to know how to use it because this was all voice activated and touchscreen activated. And they were asked to have a video chat daily, every day, 5 days a week for 6 weeks. And they also were asked to wear this micro recorder, which is this device here, to capture out of video chat interactions. So it's kind of a biopsy of time of those interactions. And what was interesting was this was more of a feasibility kind of study initially. It was extremely well received with no dropout. I actually never had seen a study with such a result, but it actually perhaps speaks to the desire for some older people to be having interactions, social interactions. There was some signal that maybe this not worked, but there was some cognitive benefit, but I wouldn't make too much of that. The other interesting aspect of this was because you get digital data, you can get other aspects for free, if you will. So the audio files could be analyzed, and so as an example, the people with MCI actually spoke more on average in terms of word counts than the conversant. So this is actually the conversant, what the person in their home sees on the screen. This was a stimulus picture that could be used if the conversation lagged, but that didn't happen that often. What I want to point out here, though, is that this measure, which is unconventional, actually discriminated people with mild cognitive impairment better than the traditional tests. And so this brings up several issues, and I call this disrupting conventional wisdom and standards. So what is the gold standard? First of all, some of the conventional wisdoms that, these were some of the original reviews of this grant, that older persons won't do a video chat every day. And I have to admit, that's probably a fair question, but it turned out to be completely wrong. It must be expensive. We see that a lot, and it's less than a $5,000 PET scan. And that's a whole other comment. And then the other question about, these automated measures, maybe they're better. They're more actually ecologically valid in terms of a valid kind of cognitive measure. But the gold standard is a artificial test. I mean, I don't know how many of you memorize lists of words every day, but but those are the standards. Then the last set of examples are primary prevention and some of the issues that come up there. So if you remember the evidence pyramid, at the top of the pyramid are systematic reviews where you're basically trying to use the power of aggregating hopefully larger scale, well-controlled studies. And there have been a number of these primarily in the telemedicine area. So this is a study from last year that suggested that there were no differences in outcomes between telehealth care and usual care. And I'm not going to get into the details of, we have to be very careful about how telehealth is defined. But the point that I want to make here is that there were still, many of these studies were rather small and were not necessarily of highest quality, perhaps. And so the evidence thus far, even for classic kind of telehealth or telemedicine, is still not that strong. And so this is something that we have to just be honest about. I know there was a recent study that was just published that focusing more on disease-based telemedicine, so for heart failure, diabetes, which suggests that actually in those specific areas there is some evidence of at least efficacy, certainly. And then the last related study that has gotten a lot of press in the last few years is the UK's Whole Systems Demonstration Project, or Demonstrator Project, which has been touted as the only or the largest randomized controlled trial of telehealth and telemedicine, where patients or seniors were, several thousand seniors were enrolled in one of two arms. Telehealth, which is more sometimes also called telemedicine, focused on disease management of particular disease areas, COPD, diabetes, and heart failure. And in that arm of the study, there was no reduction in deaths with telehealth or ED visits. I'm sorry, there was just in deaths, but no change in emergency room visits or admissions or costs. And then on the Telecare side, that's the more integrated, in this definition, kind of care system. So safety alerts, things like that. Again, there was it was hard to show a reduction in health or social care use. One of the, this probably doesn't show that well, but one of the interesting things which shows the challenge of this kind of research in general is, if you look at, these are the two groups, the intervention group and the control, in terms of their emergency hospital admissions. The control group actually had more at baseline, so before the trial. And then there was this interesting change at the start of the trial. And so interpreting these data is very difficult. But I think we have to have eyes wide open that it's not just the technology that's going to potentially confound us. So with that, I just have five sort of summarizing questions. These are in the areas of considering across the, or within these areas of primary prevention, secondary prevention, tertiary prevention, across the disease spectrum, what are the top opportunities of using various kinds of technologies? And then thinking about, as people transition across those, the different kinds of technologies, what might best facilitate aging in place. The levels of evidence, this term, what's good enough, has become now a common phrase we're using here. So what levels of confidence do we need to show that a system is effective and then really ultimately scalable and generalizable? The resources needed to achieve the answers to those questions, and the timeline. So we've talked a little bit about timelines, but I think we probably need to be a little more specific in our recommendations going forward, and I think hopefully that'll come out in the report and subsequent comments. So I try to keep on time here, and I think I did.
Okay. So I was charged with talking a little bit about designing technologies across the continuum of primary, secondary, and tertiary prevention in terms of thinking about cognitive changes with cognitive aging and dementia, and how we can do that to support everyday functioning and quality of life, and also decrease caregiver burden. So this probably is a no-brainer for everyone in terms of why this is important. We know that functional impairment in older adults has a lot of negative healthcare consequences, things like increased healthcare utilization, falls, loss of self-esteem, poor quality of life, that includes the caregiver, conversion to dementia. So this is an important issue for us to be thinking about. In terms of primary prevention, I think one of the places that this can come in is in terms of how we might be able to use technologies to help support brain health. So over the last decades, we've been learning a lot about things like exercise, cognitive engagement, social engagement, eating habits, sleep hygiene, stress reduction, all those being associated with lower rates of MCI and dementia. And in fact, it's not just in older age, but it's also engaging in these activities in middle age or even as a younger adult, that these can have positive benefits in terms of brain health. So how can we think about using technologies to support brain health? And we recently engaged in a pilot study to do a holistic brain health intervention. And I left for vacation right as our IRB got approved, and I told my students to go ahead and start recruiting. 4 days, 50 older adults in the study. So brain health is something that that the generation is very interested in, and in fact, the groups have been going great. It's really been very interesting, and something that I think we can think about how technology may be able to help us in this area. So some things that have already been talked about, wearable systems for tracking mobility and other health-related activities. So there are some things on the market. Of course, there are lots of limitations there that have already been brought up. Social networking technologies for social enhancement, so email, internet, Skype. Some things that our group and other groups have been working on, intelligent systems that can learn about the individual and their habits, and then monitor their behaviors and prompt to assist at the best times in terms of helping people increase some of these health-related behaviors. And these could perhaps come from smart homes, maybe from wearable technologies, partnering of smart homes and wearable and other sorts of technologies. Now, in terms of doing this work, we've already heard about a number of challenges, and I'll come back to some of those, but here are some other challenges that I think are important in terms of how we engage individuals, and these are, all of psychology. These are important, right? How are we going to engage people in these healthy behaviors, and how are we going to motivate them to stay engaged in these health-related behaviors? And I think there's possibilities for using technology to do that. And our group has started exploring some things like gamification, changing reward structures, social competition. So what are ways that we can actually use the technology to assist people in engaging in these healthy behaviors? Also, in terms of introducing these sort of technologies at an early age for people. So I think a lot of perception when you hear like assistive technologies has been on disability and pathology, but the importance of creating a perception that promotes more successful aging or successful lifespan development. And if we can do that, if we can make our brain technologies fun to use and more of a status symbol, maybe we can find ways to integrate these technologies in a way that will be able to promote better some of this primary prevention for cognitive aging. In terms of secondary prevention, here I think we're dealing with detecting those early cognitive changes. And this is going to be important for earlier health care, but also for the individual with cognitive impairment in terms of allowing them to be more proactive in their health care. And if we're going to introduce any sort of non-passive technologies that the person may have to learn new things, we want to do that at an earlier stage where there's time for them to become familiar and develop those automatic habits before they become too cognitively impaired. And then hopefully the idea would be that they would be able to use that technology for a longer period of time. So we've already heard some about intelligent systems, the continuous monitoring of behaviors that can detect changes in a person's health. And these changes could be both acute changes, so might signal that there's some sort of acute sickness, or more gradual, detecting changes that might suggest transition to dementia. Maybe these could be through wearable technologies, and again, we've heard about some of the challenges there. Technologies that are embedded in the real world. This probably hasn't been talked about as much today. Things like computer use or game tracking, voice monitoring, ecological momentary assessment measures of things like mood or activity level. And then smart homes, where we have been doing some work, and this is just from one of our studies where we've brought people into our smart home campus, on-campus smart home test bed, and had them do different activities of daily living. This was a more complex task where they had to do 8 different tasks, and we did a lot of complex behavioral observation of their functional performance, and then we looked at that against sensor data, and we're able to show some correlations suggesting that we may be able to use data that we're collecting from sensors to be able to tell us information about functional health. And indeed, some people, some groups, Tiger House and Orchitect, we have also started to do some of this, monitoring people over time for long periods and trying to see if you can use information to detect and predict some of those functional changes from the sensor data. And some things that have come out of the literature are things like variability in a person's daily activities, change in walking speed, as being suggestive of some sort of changes in functional status. Other secondary preventions, perhaps reminder systems, things to remind people about annual checkups, telehealth, automated pillboxes, call centers, intelligent prompting technologies. Again, we're going to see those span across the spectrum, maybe playing different roles at different points in the prevention trajectory. In terms of some of the challenges here, continuous monitoring, we've already seen this, results in a large amount of data, and it has to be stored and interpreted in a way that is going to be meaningful in terms of its use. We're also trying to create algorithms that detect low base rate events from the sensor data, and algorithms that are going to avoid high amounts of false positives, and these are all challenging things to do. We also need to validate our algorithms, and we have some that look at things like activity recognition, but we haven't done a good job yet of demonstrating the reliability and validity of these algorithms, and especially any algorithms that we want to use for health-related behaviors. And then in terms of all the information that we're gathering, how are we going to prevent information overload for the users? What type of information do they want to see? And this may differ, and our data suggests that it does differ, whether you're a caregiver or you're a nurse or you're the user themselves. Reliability and longevity of sensors, we've heard some of that today. And then also, again, encouraging that earlier device use to promote habit. In terms of tertiary prevention for cognitive impairment, here we're really talking about a person who's got significant difficulties with everyday activities, and we need technologies that can really be used to complement formal human care. Such technologies should do things like provide increased sense of safety and independence, increase confidence in performing everyday activities, allow adults to feel more active in their care, have a positive impact on their quality of life, decrease feelings of isolation, be useful in terms of energy and time conservation, decrease feelings of imposition on families and friends, decrease caregiver burden, and be cost effective. So that's a long list of things that these technologies need to be able to do. In terms of enhancing quality of life for persons with dementia, There are some products out there that do a number of different things that are very cost-effective sorts of assistive technologies, so things to promote safety like night lights and flood detectors and outlet switch-off detectors. Things for social communication, so we have picture button phones. People are developing things that can act as memory enhancers. So besides reminder watches and other sort of reminders for prospective memory, audiographers for cameras that may help with retrospective memory, and other things to support daily living like motion sensor faucets, bidets. And one of the things to point out is in developing these sort of technologies, we also want to do it in a way that's not going to increase caregiver burden. So there are some technologies out there that do require caregivers to do a lot to make the technology work, and that it is not always successful. In terms of intelligent prompting systems, which we've seen kind of come through the different types of prevention, at this stage, due to the cognitive compromise, you really need a prompting device that's not going to require any sort of feedback by the user, something that's going to alert the individual to the fact that there's going to be some sort of prompt. To be most effective, we really need something that's going to be context aware, and this is something that our group has been working on, being able to use information in the environment to know the best time to cue the person, and then if the person doesn't respond to the prompt, to have that information and then to be able to reprompt. And we've also been looking at the best time besides using that context information to prompt. So if we prompt during another activity, that's going to be another attentional load on them and could cause more errors than if we prompt during things like activity transitions. And we do have some data from undergraduate students that suggest that prompting during transition periods is positive. More people respond to those prompts. And they actually, even if they're given time-based prompts, will wait till transitions to respond. We also need to consider the best way to deliver prompts and the delivery device. So verbal, multimodal, is it going to be a TV, a tablet, a phone? Do we need some sort of cueing hierarchy? So we start out with more of an indirect cue, and then we go more directive, and then we go more multimodal. And then what would need to be sensed to deliver appropriate prompts? So, do we need to get down to the orientation of objects, to safety devices that are being used? So what are those things that are we going to need to prompt for, especially in terms of safety and everyday functioning at this stage? And then what are we going to need to know to be able to do reliable prompting? Okay, I'll just skip that. In terms of caregivers, we also have to be thinking about their needs at this stage, because they're taking care of someone who has significant difficulties and challenges. So what can we do to provide emotional support and information? And there are a lot of technologies, chat rooms, internet and telephone-based support groups, video conferencing. There seems to be a lot of literature out there to support the efficacy of these sorts of technologies for use with caregivers. Other sorts of technologies that can decrease worry and burden for caregivers, so tracking technologies, floor mats, video monitors, door alarms for wandering, object finders to help locate lost objects, and other things that may decrease additional stressors like having to travel 45 minutes with someone who's anxious about being out, like Telecare technologies that may assist there. So in terms of some of the challenges at this stage, designing those intelligent context-aware prompting technologies, designing technologies that are passive and that are going to involve no or minimal user initiation or maintenance, designing technologies that require no new learning of the user, and also that have the ability to learn about the user and then adjust to the changing needs of the user. Making those technologies acceptable to the end user, and what may be acceptable for someone without cognitive impairment may be different than what is acceptable to someone who has cognitive impairment, and so we need to keep that in mind. And then, of course, designing these technologies that are low in cost and protect privacy. And then I think just some other challenges that are a bit more pervasive too, is that in general, there seems to be a lack of awareness and knowledge about a lot of these technologies, and even some of the simpler technologies among professionals, users, and caregivers. And I've had caregivers spend hours trying to find things that would assist them, and trying to develop ways to get that information out to people so that they can be aware of these technologies is important. And we have just finished our first attempt at doing this, and we've developed a video series which will be online soon at this website that covers assistive technologies for a number of different activities, from things like memory, everyday activities, to fall prevention, hearing, vision. And so we're hoping that this will be one way. We're going to do both a web-based and going out into the community with these videos. So we'll see if that's at least one way to start getting some information out there. The need for a managed database of available devices, and I think we've seen some examples there, like Leading Age Cast has a good website there. Access to technologies and the training and support to use them efficiently. So even if we get these technologies out there, how are we going to get that training and support out for individuals? How can we use the community, maybe senior centers to help foster some of that? How are we going to partner between our different technologies? We've heard that come up. And then people's attitudes towards the devices and self-efficacy. And there's a lot of individual characteristics that was brought up earlier that need to be considered. Okay, so that's it.
Thank you. What I'm going to be talking about is technology support, particularly physical health. And a lot of the technology I'm going to use here as examples come from the Quality of Life Technology Center, which is joint between University of Pittsburgh and Carnegie Mellon. So first of all, let's set a little bit of stage. A lot of the technologies we've been developing have been looking at physical therapy, and there's a growing need for it. By 2030, we estimate that 4% of the population will have experienced a stroke, and a cost of over $180 billion. And if you take a look at total knee replacements, total hip replacements, rotator cuff surgeries, anterior ACL type of injuries, we're talking hundreds of thousands and millions total between them on a yearly basis, and rehabilitation commonly requires 6 months or more, and often these are very difficult to motivate people to carry through with their rehabilitation. So let's give a little bit of an example here. This is a blood pressure cuff, and you put it on your wrist. And we saw earlier where Sarah talked about, I think it was a glucose meter, that this one has a 50-page manual and has all kinds of digits on there in different positions. They mean different things depending on what mode the device is in. And first thing is it mounted correctly? Is it with the up or is it down? And so think about a coach that would guide the person through using this. Now, you could argue that the engineers should design it correctly and not make it so complicated. Well, sure, you can say they should do that. Will they do it? The point is we're going to have lots and lots of these technologies that are going to be in the field and purchased that are not going to be very usable. And so let's talk about how we make them usable. Now, 2 years ago, in the September issue of IEEE Spectrum, I did a cover article which is sort of somewhat visionary on using phone apps throughout a person's life. So beginning upper there, the baby in the crib, you could think about a device, an app that would basically check to make sure that the infant is not in a position that might lead to sudden infant death syndrome. So, watching the heartbeat, looking at the location of the child. The second one there was actually inspired by my younger daughter. We were vacationing, and they had a fenced-in pool, and there was a 4-digit number to press, and we thought we were hiding ourselves very, very much from it, but she figured out what the 4 digits were, and she got into the pool area, Luckily, her sister pulled her out of the pool. But geofencing, but that's not only for the young, but even for older people. In the second row there on the left is American Sign Language. Maybe a chance to learn something new, a chance for a child to communicate with somebody that's different from them. If we keep going, in the lower row we show a person with a cast. Often we have injuries and we're giving discharge instructions from the hospital, and if I've got a cast on, most people put their thumb over the handle. And that's not the way to do it, because you end up going to strain that ligament. You're supposed to do it with the palm of your hand. Most people don't do that, they don't see it, but again, we have a technology, we're rehabilitating, how do we handle it? And then in the lower right-hand corner, safe driving, helping a person to continue driving longer. So I can envision a time when there's going to be an app store, and I think Jack talked about Radio Shack, but I'm going to basically have my doctor write me a prescription. I'm going to the app store. It's going to load it onto my cell phone, which has a lot of sensors. There may be other sensors you plug in. We've been working with a company that makes a dongle for a smartphone that you plug it in, you put your thumb on a circle, and it gets your pulse, you get your oxygen level, and get your blood pressure. So you can imagine that maybe the cell phone will be the thing that will be driving us in the future. So how do we get to these devices? Well, okay, the point I have here is that apps that we develop maybe for people with disabilities could actually generally go across our population and not just limited to the end of life. So the way we do things in our center is what we do is called user-centered design. In this particular case, I'm going to give an example of a application to help remind a person in a wheelchair to change their position periodically. If you have a spinal cord injury, the lower part of your body, you can't feel it. And you need to move position periodically, otherwise developing pressure ulcers. And those are very difficult to heal. So there's things like I should recline so many degrees for so long. I should elevate my legs so many degrees for so long. And it turns out that we also want to be context sensitive, because if you tell me to elevate my legs and I'm in a supermarket checkout line, that's socially not acceptable and people will stop listening to you. So what we do is we involve the stakeholders, if you please, in the right at the beginning. So here's the case of wheelchair user and a clinician. Wheelchair user, we use some Wizard of Oz techniques to find out what type of feedback they would like, how they would like to set preferences. Turns out it's very interesting for us, for the clinicians, is we found out later that they didn't have a process. We kept asking them, well, what do you tell people when you release them from the clinic? And I unfortunately used the word prescription, and I got 160 pages of federal forms that they filled out to justify the wheelchair financing. And so we finally came up with a spreadsheet, very simple: elevate, minimum angle, maximum angle, how many minutes, how often. And did that with the legs and also changing body position. And from that, they were actually able to compare notes and were able to apply best practices. So the engineering process ended up helping the clinical process. But once you got a prototype, then you can take it out into the field and start collecting some data. And we also heard this earlier. We had 160 patients in the clinic. By the time we took out people who couldn't already have pressure ulcers and who volunteered, and that we're down to 40. Out of those 40, 10 agreed to do it, and then out of those 10, only 4 finished the study, and they're all unique. So this, again, we heard that as a challenge earlier. But the idea here is we have iterative design, and our experience is if you ask people what they want, they can't tell you, but if you give them something, they can tell you what's good and bad about it. And from that, you're able to derive the requirements. So that's really only the first stage. And actually, we have, that's the first stage on the left there, but from there, you have to do robust prototype. Well, the students build a prototype, and it's held together with bubble gum and baling wire. And it's got some hard code constants, and it crashes. You have to make a robust prototype out of it. From that, then you get a point where you can start bringing people into the laboratory and testing it. And finally, from that, you get a field deployable system and hopefully commercialization. Now, each of those stages might take an extra factor of 5, if you please, in effort as you go through. To put it out in the field, we have literally hundreds of pages of help information, audio information to help a person through it. So we have a number of these coaches, and they've been progressing through the pipeline. So let's take a look at one coach that we did. And this is a health kiosk. And initial motivation was to be able to put it in a high-rise building with senior citizens who needed to take different vital sign measurements periodically. So idea here is the person could come up, they would be told they would like to take your blood pressure in the morning, your blood oxygen before you go to bed at night, and there'd be instructions on helping them there, and the data would be available for the doctor and their caregivers to take a look at. So the first one, the early on the left, is the early IKEA furniture that students in the capstone engineering course developed. Then it went through more rapid development and user testing, and then finally into a prototype that we're deploying in the 3 organizations up there on the right. So I want to point out one thing. So first of all, this 80-plus-year-old population had basically no idea of a touchscreen. They had no idea that any place on a touchscreen could be a button. So they had no idea what next meant. They had no idea continue meant. So that is current vocabulary. So we sort of said, okay, touch here. I'm touching. Nothing's happening. It's broken. I'll never use it again. Tell my friends never to use it. Well, every software engineer in the world is taught to look for that, the release. So if you change touch here to tap here, all of a sudden, the problem goes away, and you have a great technology. You don't find that in the lab. You don't find that necessarily in a short pilot. But maybe that's the new technology that will universally be applied to, so our younger generation will learn the same vocabulary. So what's the vocabulary? What's the mental model? We've heard about that. And then on the bottom is sort of the progression of the user screen. So initially you thought, hey, it'd be really great to include a video, so if people forget how to use this sensor, they could watch the video and learn about it. And so initially the video loop, well, that didn't go over too well. So then we decided, well, let's just give them one page with all the steps on one page, so they wouldn't have to worry about paging. Well, that worked a little better, but not quite as good. So it got to one page per step, and they would sequence through the step. So again, those are the type of things that you learn in the field. Okay, so the other thing I just want to put out, Beth initially talked about the senior citizens. So we also use focus groups, and one of the focus groups they ask, do you mind if we put sensors in the bed? And an 80-year-old person, woman piped up, can you tell how many people are in bed? No. Okay. Again, that was not something that we had anticipated. But the next thing I want to do is talk about a process that we've been building with Myoma with Steve Kelly over there. So this is the engineering students, computer science students' view of an interface. So on the left-hand side, it's using Connect, and this is rehabilitation from strokes, and then there's the Connect image, and then the bar graphs and all the other things that the engineers wanted to show how well you're doing your exercise, are you making mistakes, and so forth. Well, so the next cut at that was, we've heard about gamification. So there's actually about 8 exercises that Myoma has given us, and they've been plotted out on charting a pirate island, and as you go through the island, there are different things you can do. So for example, one exercise where you reach for a light switch is a bow and arrow game. And depending on how well you do that, the arrow comes closer to the middle of the target. Bringing a cup to your mouth is a fishing game. When a fish comes near the hook, you try to bring it up. Of course, now, not everybody's able to do the whole motion. So what is the expectation for that person? How do you set their goals? And then as they do more repetitions, they get fatigued. How do you monitor the goals to encourage them, even though their actual performance is not as good as it was at the start? And then on the right-hand side, don't forget the clinician. How does the clinician set these goals for the person? And next stage is, okay, let's do the whole virtual reality. And here's a case where the person is wearing a Myomo arm brace to help provide physical motor assist for the arm. And this is a wiping motion. And the person is moving these paddles around and controlling a hang glider, and then in the virtual space. And then where you put your targets determines what motion that the person's doing, so we can encourage specific motions. But in addition to exercising the arm that has a disability, you're also exercising good arm and a coordination between the two arms, and the coordination has also been forgotten. And then where we're going from now is a dialogue between the coach and the person that more simulates the actual dialogue that a human assistant might have. So we do a variety of word spotting and also emotion detection based on the prosaics of the language, so we don't even need to know what the person's saying. So here's a case where we ask them if they want to start, and then you encourage them, and it looks like they might be deteriorating. You might ask if they want to take a 15-second pause, and then go to another exercise. If it looks like they're frustrated, you can actually move to an exercise they've been more successful with, and if they start showing angry or pain, then you just tell them, well, it's enough time for today, let's move on. And to do all of this, it takes a village. These are all the disciplines that were involved in that coach. And so getting these people to work together is also part of the challenge. So let me just end up here with sort of a personal story. This is, my father's on your left, my mother's on the right, and they passed away. And my father had congestive heart failure. My mother basically, eventually, in a series of strokes, she passed away. But the things that went through, like the medications, my mother had 23 medications. Nobody checked to see, they're different doctors. The doctors didn't talk to each other. My father didn't want to have extraordinary means to continue life, but we had no idea what was going on. He was very confused. One day he said, you can drink as much water you want. Next day he said you couldn't have any water at all. And we found out, I understand later now, the way congestive heart failure works, what was going on, but we didn't understand it at the time. And then we came in one day and was seen right out of ER, people running around, closing drapes, alarms going off. And at this point, his blood oxygen had gotten way down, and they put him on dialysis. Now, if you'd asked me about dialysis, I thought it was extraordinary behavior. It would have to be used for the rest of his life. We'd have probably said no. Well, it turns out they use dialysis as a dehydrator. It takes water out of the blood. They took 25 pounds of water out of his blood. He never did dialysis again, but nobody told us that. And but at some place there is a threshold, I don't know if it's economically driven or what, that it was conceivable to use dialysis. And then finally, doctor, he had diabetes. His brother died from diabetes, had legs amputated, and they told him they're going to amputate both his legs, and not notifying anybody, and that was sort of the last straw. But I'll get to brighter things in a bit. My mother, on the other hand, she had to go into the nursing home for rehabilitation. They changed the physical therapist people. I had to work with them to get the release because the doctor in the nursing home wouldn't return any calls. And at one point, she had to read her blood sugar. They thought she had diabetes. We didn't think so, but the rules were you had to take your blood sugar level and report it every day. She was in assisted living. In the state she was in, it was against the law for the people in assisted living to take something like blood sugar. And if she couldn't take it herself, she had to go into the nursing home. And everybody knew that if you left assisted living in a nursing home, you didn't come back. So that's certainly not something that you wanted to go through. So luckily, she was able to do a lot of the mechanical things. And I'd call her up at 7 every morning, and I could tell by the beeps that the device was giving which errors she was making, that she put the strip in upside down, didn't leave it in long enough, and so forth. And so we were able to get our way through this, and then they took it away and said you didn't need to do it. But here you can see where a virtual coach would have helped. But when she did go in for rehabilitation, they placed her in the room next to the room my father died in. And in addition, the person who was a roommate was crying to be, let me die every, through the day and night. Just no concept of the history that went on there. And then they wanted to put a feeding tube in. And we were really concerned about that as being extraordinary measures. And it was a hard decision for me, am I going to starve my mother to death by turning that down? So we put her in hospice. They removed the IV, moved all the medication. Within 24 hours, she was able to sip, ice chips, and then she went on from there. And I found out later that, they sedate people in the hospitals. They pump them full of fluids to keep them quiet and so forth. And we didn't realize that, taking these things away would perk up. And basically, we did find a position for her in a home care. Somebody took her into the home, and she was amidst 6 kids running around. She had a 95-year-old sidekick that watched TV with her, and it turns out it was right above the beauty parlor where all the people, women from the neighborhood gathered on Saturday to exchange gossip. Something I would not have been able to do from a social point of view if she came to Pittsburgh. So anyway, but there's several opportunities here in communications, providing some model for what's going on in the body so that the caregivers understand that they're not making these decisions in the dark. And knowing that there's possibilities, making up matches for home care. I didn't know that was a possibility, and that there were people willing to do it. And fortunately, we were able to stumble across some of these things. So anyway, there's some opportunities here through these examples that I think we can look for improvement. And then there are barriers. You heard a lot of these today. Fundamental knowledge, noise, and uncertainty, differences in unpredictability between individuals, different contexts, complex interactions, safety, robustness and generality, interoperability, privacy, market factors, user acceptance, and so forth. All of these, I think, in one form or another, we've heard earlier. And then my questions have a lot to do with, how do I deal with the technology? How do we keep it from being thrown away and abandoned early? A lot of technologies abandoned within a couple of months. We've heard that. Things are complicated. How can we simplify them? How can technology adapt to my ability as they change? Matter of fact, the director of our center, Tadeo Kanadi, had a simple equation. What I want to do, what I'm able to do, the difference is bridged by technology. So I want that technology to change as I change, even throughout the day. And can we use technology to motivate change of behavior, which is one of the hardest things to do? How can we have the interchanges more like humans so we have more social? And then how can interaction change as I go through a session, even if my mood changes? How can I ease the burden on caregivers? And how can I support the team, the doctors, the nurses, the engineers, and synchronize them through the design and implementation of these systems? So these are some of the questions that I had, and at that point, I'm finished.